Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Allan Meldrum, a third-year anesthesia resident at the University of Saskatchewan in Saskatoon, discusses the use of social media as a tool for medical education. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time. My name's Allan Meldrum. I'm one of the third-year anesthesia residents here. And today we're going to talk about medical education and social media, or this idea of #MedEd. So the objectives as outlined here are to examine the current state of medical education on social media. We'll critique current medical educational material on social media using a variety of validated tools and some that are unvalidated, but very interesting. And then we'll put that all together to develop a couple of frameworks to create higher quality medical educational material using social media. So practically what that's going to look like, we'll take a quick overview of the current social media landscape. We'll delve into developing your own social media toolbox. We'll look at, 4 frameworks to appraise and create social media-based materials. Look at a few examples in anesthesia specifically, and we'll take a brief step back to take a look at the future of social media and anesthesiology. In terms of disclosures, I do run the USask Anesthesia YouTube channel, so I have a vested interest in social media, in education, and in anesthesia. And I've created a few video-based educational materials as part of my research project. And I also co-produce the Airway Breathing Conversation podcast with a few of the other residents here and regularly post on social media about it. But none of that will be explicitly promoted or referenced, and none of it is monetized. Though I will mention a couple other projects that are being also worked on in the department with respect to social media. So starting with our overview of medical education and social media, I think any good overview starts with a definition. So to define social media by the Merriam-Webster dictionary, they call it any form of electronic communication through which users create web-based communities to share information, personal messages, ideas, and other content such as photos and videos. And that's a good definition just within a box of itself. But to give a little bit more historical context, there's a paper by Kaplan and Heinlein that describes it as a group of internet-based applications that build on the ideological and technological foundations of Web 2.0 and that allow the creation and exchange of user-generated content. And so for a little bit of context there, Web 2.0 was this term coined in the late 1990s, describes the internet as a read-write platform with dynamic interactive content that's typically more user-generated. That's in comparison to Web 1.0, which was the very early internet, the early 1990s. It was more read-only. There was no interaction, just people posting things. Today, we kind of mostly live in the Web 2.0 era, though there's some sense of a Web 3.0. That is this read, write, and own that's typically more decentralized and has more focus on blockchain and AI. Though I think it's safe to say we're still pretty firmly in Web 2.0 for the time being. There are many, many different forms of social media, though broadly, very broadly, you could group them into 5 major categories, though there is a lot of overlap. The first being written content, things like blogs, X, Twitter, Mastodon, other things that are more text-based. There's audiovisual content, things like YouTube, Instagram, TikTok, and many, many others. There are platforms that focus more so on cross-posting or taking posts from other sites and then posting them through their own accounts, so things like Facebook, LinkedIn, Pinterest, though they do have their own original posting features as well. You have messaging apps, things like WhatsApp, Facebook Messenger, Telegram, though most social media platforms have their own form of direct messenger as well. And then there's live streaming, things like Twitch, Facebook Live, Instagram, and a number of others. So looking at medical education specifically in social media, in 2005, about 5% of Americans use social media. You can compare that to 2017, where it was over 70%. And I would feel like today, if we were to take a poll, it'd be well over 95% of people, not just Americans. And it was noted that over 50% of patients use social media as a means to access healthcare information. And that doesn't just include patients, that includes medical trainees and physicians as well, because we're also increasingly using social media to gain further knowledge. There's a 2020-2021 study that showed that 70% of physicians in the top 10 US hospitals had at least one social media account, and it's only grown since then. With the COVID pandemic, a lot of things going virtual, the interest in social media medical education increased significantly. For reference, the term hashtag MedEd on TikTok at the end of 2020 had over 4.6 billion views. And despite all that, though, only 40% of the general public trusts information that they find on social media, whether that's medical or otherwise. So definitely a lot of mistrust. With respect to anesthesia and social medicine, in social media, there's also been a significant rise in interest over the last decade. If anybody can identify all the people on the right there, they'll be impressed, but they're all pretty significant anesthesia medfluencers. And we see more and more growing every day. We see an increase in social media use specifically for health information by individual anesthesia providers themselves, not just the general patient population, especially after COVID pandemic. And there's been this rise of visual platform popularity for dissemination of specifically regional anesthesia material, just because you're able to see the procedures a little bit more clearly than just being described by text or by still pictures. With respect to anesthesia networks and societies in 2022, about 50% of all the national anesthesia societies in the world had at least one major social network between either Twitter, Facebook, YouTube, and Instagram. And both the American and Canadian societies currently, as of today, have accounts on all four of those. So we could spend all day looking at every single different platform, all the research on each platform, and whether anesthesia has any role on each platform, but that would take quite a while. So we'll focus on the top 5 by monthly average users, those being YouTube, Facebook, Instagram, Twitter or X, and TikTok. Most of these have some anesthesia-specific content, but there's surprisingly little currently available, so it's definitely an area of active research. So if we go to YouTube first, a little bit of history. It was founded in 2005, and now it's owned by Google, and has the second highest internet traffic globally after Google search itself. And as of January of this year, there were 2.7 billion monthly active users watching over 1 billion hours of video every day. There are a number of popular YouTube medfluencers, including Osmosis, Medcram videos, and Dr. Mike, as well as others just randomly picked. On YouTube, there's one major paper from Nelms in 2024, which is a systematic review, critiqued the overall quality of educational YouTube videos on perioperative anesthesia. It found almost 9,000 articles, filtered it down to 14. And amongst all of those that critiqued, just about 800 videos, 60 hours, and 47 million views. Most of the papers came out after 2020, or about 50% of them. So it's a pretty active area of research. And article topics included things like regional anesthesia, vascular access, intubation, obstetrical, and general anesthesia. Their systematic review found that 86% of the studies reported the educational quality of videos as poor on YouTube. And the study quality itself, using the systematic reviews framework, was either 50% fair or 50% good. What was interesting was that there were 17 different tools used to assess the video quality, so they couldn't actually perform a proper meta-analysis or subgroup analysis just because of the large heterogeneity of the tools used. They found no statistical differences in the proportion of videos rated as poor amongst anesthesia techniques studied. And they found that about 1/3 of the videos were uploaded from educationally reputable sources, things like academic institutions, healthcare organizations, physicians, and the like. But another 1/3 didn't have an upload source reported, so we really had no way to fact check their credentials. They left a list of recommendations that I'll summarize. Essentially, they recommend using validated instruments, and we'll talk about some of them later. They recommend tracking and reporting factors that contribute to decreased quality to allow for subgroup analysis. They say that if you're going to make your own instrument, explain why and how. They explain that you should use multiple raters for scoring and develop some sort of an inter-rater reliability, something like a Cohen's kappa. You should report social media specific metrics, things like uploads, sources, target audiences, likes, follows, that sort of thing. And that you should give specific recommendations for how to improve the quality as well. We look at this other umbrella review from 2024 that looked at a number of different social media outlets. They find similar results. They looked at about 2,000 articles and filtered it down to 15. They found that YouTube was the most commonly used medium for dissemination of health information, but that the content significantly lacked quality. Over 50% of the videos had no evidence-based information, 50% were uploaded by non-professionals, and over 70% didn't cite any references. And only about a third of them, again, were neutral or didn't have any significant bias. So overall, despite the large repository of educational content, YouTube has a long way to go in terms of quality and trustworthiness. Moving on to Facebook, originally in 2003, it started as FaceMash, then Facebook in 2004, or rather the Facebook, and then just Facebook in 2005. And as of 2021, it's part of Meta. Facebook is a little bit different in that it's primarily more so about sharing content, not necessarily creating content now, though you can still create content specifically on Facebook. It is the largest social media platform globally, just a little bit over 3 billion monthly active users. And there's significant crossover with other social media accounts, hosting many official pages to represent organizations, things like hospitals and universities. Though the ability to have private groups with anonymous posting does signal for potential for less than academic endeavors. So things like these anti-vaxxer groups, even though Facebook does say they actively work to delete and remove groups that spread information or disinformation. A 2013 systematic review found that Facebook and Twitter generally had moderate quality in university-based healthcare education. It found that Facebook and Twitter were both perceived as potentially useful in a blended approach to classroom teaching, and though some students had reservations about faculty members spying or infringing on their virtual social community, since typically Facebook itself requires you to identify yourself as yourself and not necessarily anonymously. And there were some reservations about the boundary between the student-staff relationship. In 2014, there was another systematic review that focused on medical student teaching and digital professionalism. And to summarize, it found that there was no conclusive evidence regarding the impact on actual competence, even though medical students did accept Facebook more so as a source of teaching, primarily for preparatory work and group projects, things like exam prep, sharing online materials, and case discussions. In 2019, another systematic review reviewed Facebook, found that it's generally effective for academic communication and promoting student-centered learning, though most studies that it found were self-reported and pre-experimental, so they were mostly observational studies, so it's no control versus treatment or randomization. And the actual effects, again, on performance are mixed and understudied, so it may not be suitable for teaching in all disciplines. Back to our umbrella review, they noted that Facebook had more of an emphasis on groups and gamification. They found it helpful for anonymous posting for things that people might not be comfortable talking about using their actual identification, things like sexual health education and promotion. But they actually found higher rates of dissemination of misinformation, false information, or disinformation than YouTube or Twitter. Moving on to Instagram, originally came out in iPhone in 2010 and Android in 2012. It was purchased by Facebook in 2012. And it has about 2 billion monthly active users, so it's the third most popular social network by that metric. Focuses more so on audio-visual content, either as long-standing posts or temporary stories that disappear after 24 hours, but have a little bit more engagement potential. It's similar to YouTube, only in the sense that it's more about content creation than necessarily cross-posting, though you can do that. And this is where we start to see the rise of many, many more medfluencers and some randomly picked names there, with some having up to 2 million followers each. Instagram specifically is where we start to get into a lack of rigorous study, potentially due to the significant number of posts out there and the poor searchability of terms for Instagram. Though there was a 2024 survey of anonymous medical students that noted that about 2/3 of them had obtained health information from Instagram, 15% specifically visited Instagram for healthcare information, and about 5% found the health info unreliable or inaccurate. So actually surprisingly lower than I would have thought. And about 70% found health information on Instagram was beneficial, but the quality and usefulness was about average and could be improved. In 2021, some UBC residents founded this resident as teacher educational intervention that consisted of 17 weekly structured resident-led educational sessions from 15 medical specialties. They posted freestanding clinical pearls, specifically relevant to the COVID era. And it was generally received positively, especially for image-based specialties, so things like dermatology, radiology, and infectious disease. Then our umbrella review, again, noted moderate to high quality for Instagram, actually, but that a lower proportion of users are seeking health information here compared to some other platforms. Onto our fourth platform, we have TikTok, one of the more recent additions to the social media landscape. It was released in 2016, previously called Musical.ly or Lively, and now globally it's TikTok. In China specifically, it's Douyin, though it's pretty similar, but has a couple other changes that are only available in China. There are about 1 billion monthly active users as of May 2024, and a little over a third of those are aged 18 to 24 years of age. They're typically 3 to 60-second videos, though they can be up to 1 hour if they're posted a certain way. And again, they're very focused on content creation, though shifted more so towards very short, fast-paced videos. It's a very new area of study. There's even less research available, and our umbrella review didn't have any systematic reviews yet. Though there was this one very interesting paper from 2023 that we'll look at a little bit later, where they created a toolbox for effective medical education teaching on TikTok. And of note now, they talk about this idea of micro versus nano learning, and that micro learning is this short-term learning activities chunked into smaller units based on a learning objective, and then nano learning is essentially condensing that down into even more smaller units of micro learning that could be potentially suitable for a TikTok platform. Onto our final platform, we have X, formerly known as Twitter. I'll use them interchangeably throughout this presentation. It was first released in 2006 and took about 3 years to have over 1 billion tweets, and then it was bought by Elon Musk in 2022 and rebranded to X. Currently has over about 500 million monthly active users, and these are primarily short text-based posts, so they can be links, they can be original material, though in general, nowadays it tends to be a little bit more about sharing information than creation specifically. You can find virtually every Medfluencer or official page on X or Twitter. And there's been this increasing rise in popularity amongst the medical community of online journal clubs that has a specifically reduced character limit on X. I believe right now it's 280 characters or so. So responses are typically more digestible, and it forces people to be a little bit more concise in their posting. A 2021 systematic review of medical education in dentistry schools noted that all of the articles they were able to find were survey-based, and the general quality of the scores ranged from 8 to 12.5 out of 18. So really that kind of middle of the road to slightly poor range. It noted a significantly low level of ads, and the free registration of Twitter was nice, but that there were significant barriers to privacy and professionalism. In 2022, another systematic review on the educational benefit of online journal clubs was taken. And it found that there's a significant uptake increase during COVID, and that there was high satisfaction and equivocal to increased preference of online journal clubs due to the ease of access, diverse participation, and that there was less time and cost spent traveling when you could do it from your own phone. Though there were, of course, disadvantages, specifically the lack of discussion intensity, technical issues, and limited interaction, since everybody just has their own platform or their own account to post from and read other people's accounts. Finally, back to our umbrella review. In general, they found Twitter beneficial for the promotion of physical activity and health nutrition. And then they specifically found some mis or false information specifically to breast cancer or tinnitus, though nothing specific to anesthesia that they could find. So if we take a step back and look at the overall quality out there for YouTube, there's significant variability in quality. And there's definitely the potential for information overload since there's so much content. For Facebook, it might be good for communication and organization. Its anonymity in certain group settings can be helpful to promote health equity and supplementary teaching, though it's unclear if this actually translates to improvements in educational outcomes. Instagram itself is poorly studied. It's generally accepted by modern medical students, especially for visual specialties, but there's still definitely the risk of misinformation. TikTok is generally very poorly studied, so it's hard to know really if there's anything specifically good or bad about it at this point in time. And then Twitter is similar to Facebook. It has good communication. There's the potential for these online journal clubs, but it generally lacks quality, reliable information. So to summarize further, we can talk about the good, the bad, and the ugly here. In terms of the good, it's easy to upload high quality information for rapid dissemination if you have that content available. Social media can be used as a supplement to enhance educational interactions. There's the potential for professional collaboration and network building and anonymous discussion about sensitive topics, making it a lot easier for patients with rare conditions to connect and talk about their experiences. Unfortunately, it might be too easy to upload content since anybody can do it and often anonymously. There's a significant proportion of mis, dis, and over-information provided by unqualified people without evidence. These poor quality social postings lead to a negative impact on the implementation and promotion of social media in healthcare, and it can garner patient mistrust. And then this idea of information overload makes it difficult who to trust or who to know who to trust, simply because it becomes a battle of who's more convincing or who has more followers and likes rather than who's actually right or more evidence-based. Many platforms were not initially designed with education in mind. They were much more about driving engagement and advertisement sometimes and entertainment rather than education, people stopping to take a moment to actually learn. And the research area in general is lacking high-quality, rigorous study. So our next section will hopefully develop some tools that will improve that level of study, either in a more research academic sense or just in your day-to-day. And we'll break it down into a couple different types of tools here that'll hopefully have some benefit to your future social media perusal. Our first category is quality and reliability. So we'll start with the most subjective score here. It's something called the Global Quality Scale, or the GQS. It was originally developed in 2007 to analyze inflammatory bowel disease patient information resources on the World Wide Web, which I love that they called it that still in 2007. It's a 5-point Likert scale subjectively to just quantify flow, quality, and completeness of information. So if they assign it a 1, it's poor quality, poor flow, poor information, or missing information, and it's not at all useful. And then a 5 just represents excellent quality and flow, and that's very useful for patients. So a quick 1 to 5 score to talk about patient information on the internet. If we look to another score called the Discern score, it was originally published in 1999 for written patient information, not for videos or online tools. It has 3 sections, one for reliability that has 8 questions, one for quality that has 7 questions, and then one for an overall rating. Each question has a scale of 1 to 5, and so you get a final score out of 80 for this one. So a little bit more rigorous, a little bit more well-defined in terms of different subsections. Because that Discern was specific to written information, they developed a modified Discern scale in 2012, specifically for this paper that was looking at rheumatoid arthritis information on YouTube. They modified it in that they focused more so on the reliability section, and they reduced to only 5 questions that are either yes or no. So as you can see there, they talk about the aims, whether they're clear and achieved, whether there are reliable sources of information used, whether the information is balanced and unbiased, whether there are additional sources of information listed for reference, and if there are any areas of uncertainty mentioned. So they did a score out of 5 based on the modified Discern. Moving on further, we have the JAMA score. It was developed in 1997, originally to identify standards for medical information on websites. It was not originally developed for patient information media, so written or video. It's just about websites about medical information in general, regardless of the target audience. And interestingly, it's only called the JAMA score because that's where it was published. The authors themselves don't actually call it the JAMA score. They don't give it a name. It's a 4-point Likert scale for overall reliability and accuracy that's broken down into 4 categories, namely authorship, attribution, disclosure, and the currency of the website. Moving on again, I guess chronologically back a little bit to 1996, at the very early dawn of the internet, we have this Health on the Net Code of Conduct that was created to identify honesty, reliability, and evidence-based information on websites with medical information. It has 8 core principles, namely authority, complementarity, privacy, attribution, justifiability, transparency, financial disclosures, and advertising policy. Of note, this group just certifies websites. It doesn't actually check whether the information is accurate or follows these principles. It's more so that the owners of the website have said that they have respected these principles, so it's more of an honor system. And of more interesting note, it stopped certifying in 2022 and was decommissioned later that year, so technically can't get any certificates anymore from this group. You have the LIDA instrument, which is a validated tool developed to more objectively assess the quality of digital patient health information. It has 3 categories, primarily accessibility, usability, and reliability. And the overall emphasis is more so on the user experience specifically. All of these are added together to get a final score out of 168. Though that can be used qualitatively to identify weaknesses and strengths. It can be used quantitatively to rank and compare sources or to assess individual pages versus the website as a whole. And they actually updated it back in 2018 to improve accessibility with respect to website visuals to help those who have a more difficult time looking at digital material. Moving on to readability scores. Readability scores in general use some combination of sentence length, word length, or the number of syllables per word to generate an appropriate associated, usually American reading grade level. For reference, patient material is typically supposed to target about a grade 6 or lower reading level, though one study noted that the vast majority of online medical information is written out at least a grade 10 up to even a grade 15 level. So these university level reading requirements that just don't fit for the general public. Most of them are for English language, but some include scales and indices for different languages. There are a lot of them. So if we just look at a couple little specifics here, we have something called the SMOG, which is a simple measure of gobbledygook. It's good for longer texts, so articles, reports, and books, and it's based on the number of polysyllabic words. You have the Flesch-Kincaid grade scale, which is used for educational and publishing works, again, based on sentence length and word complexity, so syllables. Then you have the Gunning-Fox index, which is used for digital content specifically, including articles, documents, and then also textbooks. And it's based on the average sentence length and percentage of complex words. Some of these include visuals. So you have something like a Frye graph, which plots the sentences per 100 words versus syllables per 100 words and gives coordinates corresponding with grade zone. So there's an example there where you would match the X and Y axes and then find a corresponding grade level. And then similarly, you have something called the Raygor graph. This one, a little bit different. It's just plots sentences per 100 words versus hard words, which they define as words over 6 characters per sentence. And then again, also gives a coordinate corresponding to the grade zone. There are many other examples of readability tools, but in general, you just want to try to find a score that's going to match the type of material that you're reviewing is hopefully validated for the same. The American Agency for Healthcare Research and Quality developed this other tool called the Patient Educational Materials Assessment Tool, or the PMAT. They have a written material and an audiovisual material version, though they specifically say it's not applicable to websites. But it's designed for healthcare providers, professionals, health librarians, and others to provide high-quality materials to patients and consumers. And their two major categories are understandability and actionability. So by understandability, they mean that patients can process and explain key messages, so things like content, words, choice and style, and organization. And then by actionability, they mean that patients can identify what they can take away from the material and can act on instructions provided within it. So how to take the actions, and that there are instructions that are simple or there are examples with visual aids. They get a point for each sub-item, and it's separated into an understandability and an actionability score. To our little final category of tools specifically, we have the ability to assess social media impact itself. And the first tool mentioned here is the Social Media Index, or the SMI. Of note, it was developed in 2015 by some of our own faculty members, notably from emergency medicine, Dr. Brent Thoma, as well as Jordan Stieg as a medical student, my apologies, one of the anesthesiologists currently at our hospitals. It notes that typically there's no peer review process in social media and that you can't use the same citing metrics as with standard journals, so things like impact factors. And so it's harder to know who's more reliable from a social media standpoint. So they developed this tool that takes into account website rankings as well as social media followership. Their website rankings took a look at something called Google PageRanks and then something called Alexa Ranks. Of note, this Alexa was not related to Amazon and had been running since 1996. And then for social media followership, they looked at Facebook likes, Twitter followers, and then Google Plus followers, though ultimately the number of Google Plus followers was so low that it was ultimately removed from the calculation. So just based on Facebook likes and Twitter followers. They noted that each of those 4 variables was validated against a comparable statistic for journals, so things like impact factor and other metrics. They developed 3 formulas, of which a logarithmic form was the most robust. And then the variable scores themselves are normalized and summed, so you get a final score from 0 to 10 for this SMI. And they proved it to be a stable indicator of impact for medical educational websites, potentially indicating a possibility for a gold standard in social media space for impact factor analysis. However, unfortunately, because this was 2015, things have changed in the last decade or so. Google Plus shut down in April of 2019. Alexa PageRanks stopped in December of 2021. And Google PageRanks is still available, but not generally to the general public. So you're just left with Facebook likes and Twitter followers. So another solution was clearly required. So this is where you enter the Digital Impact Factor, or the DIF. It was developed just last year and incorporates modern measures of website authority and reach. For authority, so replacing the page ranks metrics, they looked at the Ahrefs domain rating, which is a scale from 0 to 10. It's a freely available metric, and it awards points to websites that are essentially conservative with their outbound links and are directed toward from high-ranking sites. So it's very similar to an impact factor for a journal, which is essentially some ratio of the inbound citations to the outbound publications. They took this authority ranking out of 100 and scaled it down to a score out of 5. And then they also gave a social media reach that looked at the followership of 8 major social media platforms and scaled that down to a score out of 5. Those 8 platforms were Twitter, Facebook, Instagram, LinkedIn, Pinterest, Reddit, TikTok, and then YouTube/Vimeo. They added these 2 scores together to get a final score out of 10 to maintain direct comparison with the SMI. And they found that there was generally quite good agreement with the SMI, and now it takes into account more social media platforms. So potentially another way to assess the impact of modern social media materials. One that was very interesting to me that I found here is something called the Podcast Success Index, and it is specific to anesthesia. It was developed in 2016 to describe factors associated with the success of anesthesia podcasts. So it's very relevant to our own department's social media exploits. They essentially reviewed all anesthesia podcasts found on iTunes, and of the 85 podcasts they found at the time, only about a quarter were still active, and the median longevity was about 13 months. It primarily targeted anesthesiologists and focused on clinical topics. And for the PSI score itself, they initially wanted to look at the episodes per month, months active, the user rating, and then the number of downloads or plays. But these last 2, they weren't actually able to look at in 2016 just because it was such a niche area. They didn't have freely available download or play information, so they were only able to use the episodes per month and months active. Because we now have the DIF developed, it might be interesting to follow up and redevelop this PSI as well to incorporate more of a social media impact score as well. But in comparing their PSI to possible predictors of success, they found that a higher PSI or a higher podcast success index was found when fellows were part of the target audience, when the topics were broad, when there was a social media presence associated with the podcast, and that there was evidence of peer review, again, going back to that evidence-based resources. And they found that shorter episodes were actually tending against high PSI. So people in this type of demographic that are listening to anesthesia podcasts typically wanted a little bit longer episodes to get into the meat of it. So you might be feeling a little bit like this comic from XKCD right now. I love it because it talks about how standards proliferate. Typically, there's a situation where there's 14 competing standards or 14 different tools that all try to provide this gold standard. Somebody says that 14 is way too big of a number. They need to make one that's just going to cover everybody's use case and everybody get excited. And then inevitably in the future, after they've developed it, now you have 15 competing standards. So there's always going to be a number of tools with a huge amount of overlap. But I think the key characteristics that should be critiqued amongst all these tools that we've kind of looked at is that you find information is reliable, that it's quality, that it's accurate, and that it's evidence-based, that the material is accessible, readable, easy to use, and respects privacy, that there's transparency, that bias is minimized, that conflicts of interest and advertisements are identified, that the information is current and updated regularly, and that the impact and the reach of the hosting platform or account is also noted. There are many, many tools out there already, so don't feel like you have to reinvent the wheel. And you don't have to use these tools specifically in your day-to-day perusing, but these are just some characteristics that might help you identify more appropriate educational material on social media. Or if you're going to do studies, use some of the tools that are specific to the type of media you're looking at. So now that we've looked at the current landscape of social media, we've taken a look at a couple individual tools. I wanted to note a couple frameworks that have been developed to take it to the next level. Whether you're appraising information on social media, whether you're looking at studies that use social media information, or whether you're interested in conducting your own studies or making your own material. So the first one will look at the appraisal of health information on social media. And this comes from a 2-part study in 2022 by Dr. Ryan D'Souza. This first part focuses more so on the interpretation of healthcare information, and then the second part that we'll talk about in a moment looks at studies that use data from social media and how you can critique those. So for this first part, they note that over 40% of healthcare consumers use social media for healthcare information, and 90% of patients aged 18 to 24 believe the healthcare information that they see conveyed on social media. Compare that to earlier when we talked about 40% of people in general mistrust the internet. There's a significant swing to the younger generation trusting what they see on social media, specifically related to healthcare. And they also note that the challenge is not finding information, but more so assessing for credibility and relevance. It's this information overload that there's so much out there. It's really hard to know which is the best and which is actually going to be reliable and evidence-based. So they developed their framework using a few of the tools that we've already talked about today, specifically the Health on the Net Code of Conduct, the Discern tool, the JAMA criteria, and then the LIDA instrument. And they basically broke it down into 4 different categories. They said, how trustworthy is the material you're reviewing? How accessible is it? How usable is it? And what is the privacy and the confidentiality component? Moving on to frameworks that appraise studies using data from social media. So now we're looking into studies, not just the medical information itself. That was our part 2 that we previously mentioned here. They note that almost 50% of patients consult online sources before talking with their healthcare providers. So patients are even looking at these studies before consulting their healthcare provider due to the ease of accessibility, convenience, and immediacy. And so just as social media use has grown exponentially, so has the body of studies using data from social media in healthcare. But these studies can be misleading if conducted and reported poorly. And it's important for us to know what our patients are actually looking at so that we can know the quality of the information they're reviewing. So they set out first a couple of guides about when it's appropriate to study social media or use data from social media outlets in your study. And they note a couple examples here, specifically when you're evaluating content accuracy. So say the proportion of misleading information on a site, like we've talked about previously. When you're looking to survey healthcare consumer values, attitudes, and preferences. When you're looking to assess for personal patient experiences with disease or treatments. When you're determining appropriate public communication strategies. So this was very common during COVID. And when you're trying to establish a research agenda. So finding something like a gap between the patient and the researcher's priorities. So it's very patient-centric type of care. And so their recommendations from their framework, again, a few different categories here. They adopted their framework from the methodology for the JAMA User's Guide for Systematic Reviews. And they asked just a few questions here. They say, did the study explicitly address a sensible question? So was the topic suitable to using social media data? Was the search comprehensive? This one I found very interesting because they mentioned not just looking at, say, cholelithiasis is the search term, but looking at gallstone disease or things that the general population will look for more so. And then even going one step further and searching terms that are misspelled. So gallstone maybe with one L, just so that you're getting as much information as possible as far as what people are looking for. You can also look for appropriate search filters. So anytime you're searching on social media, especially things like YouTube, you can look for most popular or most recent, and those will give a different perspective on what people are looking for. They ask, was the study process reproducible? Was there an appropriate synthesis method? And what was the certainty in the findings of the study? So that certainty breaks down into 4 other little sections, specifically study limitations, adequate observations, explained inconsistency, and indirectness. So for example, if you're looking to Twitter for the amount of statin use, you're not going to find the correct target patient population because over 95% of Twitter users are under the age of 40, and most under 40-year-olds are not on statins. So there's likely a mismatch between the platform and the target audience. Moving on to another framework here, this one is looking into actually conducting studies. So if you're interested in doing the research and you want to use data from social media, a lot of this is very similar to the last framework. So we'll go through it briefly here. They suggest that you frame your question appropriately for the social media evaluation. So using something like a PICO framework for quantitative studies and a perspective for qualitative. They note that you should identify social media outlets and selection criteria for your content. You should systematically extract your data using something like a PRISMA framework, using interrelator agreement indexes, as well as information like disseminated, or information that's going to give you a hint at the amount of dissemination. So things like likes, shares, followers, that sort of thing. You should assess the content quality and look for bias using some of the tools mentioned previously in our last section. You should analyze the data by key variables and grading scales. And then you can interpret the findings using summary figures, something like the grade tool for confidence. And then you should compare it with traditional methods, as well as provide actionable items and suggestions. I wanted to look at this one last framework here because it was very interesting, and it actually provides a framework on how to create medical information specifically for TikTok, since it is kind of considered the new frontier of medical education. It's very cutting edge. There's not a lot out there for it right now. So this is the paper itself, 2023, by Lacey and Price, and they call it #MedEd, the TikTok frontier of medical education. They note that social media can promote self-directed microlearning and that TikTok's repetitive short video style lends itself well to micro or even nano learning like we discussed before. And the ability to comment, like, and share allows for immediate quality improvement feedback for the creators themselves. So this is all founded on something called Mayer's principles of multimedia learning. And within that, they talk about this idea of cognitive load theory. So essentially, cognitive load is just overwhelmed when there's this increased off-task activity, this lack of engagement with the assessment material, or the inability to retain content. And that's going to be influenced by a number of factors, including prior learning, environmental factors, and individual educational needs. So, for example, people who are neurodivergent or have autism. There are three main components of cognitive load, specifically the extraneous load, which relates to irrelevant details and non-essential distractors. You have intrinsic load, which is your working memory effort and the material amount and complexity. And then the germane load, which is the learner's effort, motivation, and the teacher's delivery. And so Mayer's principles includes three assumptions about learning, primarily that dual channel learning enhances information retention, so things like auditory, verbal, and visual pictorial. That active processing indicates that new knowledge should be integrated into pre-existing knowledge schemas. Examples of active processing being problem-solving games, role-play, and creativity. And there's this concept of limited capacity, so that further inputs into your working memory actually result in more memory loss. And it's this integration of Mayer's three principles into this cognitive load theory that results in better multimedia design. So they give some examples where they map the two directly. Specifically, that extraneous load comes from limited capacity to add to working memory. Intrinsic load is affected by redundant duplication or distracting the audiovisual material. And the germane load, so this motivation or effort, is affected by the type of material itself. And that people will learn better through active processing more so than passive, so better than reading or flipping through a PowerPoint. And so they give a number of recommendations as well, 10 of them listed here. TikTok itself is very audiovisual by nature, so it's great for that dual activation pathway. And it's very customizable, and it's also very short form, so it necessitates avoiding complex analysis or repetition. Some of these recommendations include having clear topic and learning outcomes, concise coverage, clear flow, consistent designs. If you're going to narrate, only keep it audio so that a visual distraction isn't present, and then adapting based on the feedback that you get from people's comments and the amount of likes and shares. So our second to last section here is just a couple of examples in anesthesia of #MedEd in social media. We've already talked a little bit about regional anesthesia here. So a lot of people are familiar with NYSORA. They have quite a selection of YouTube and Instagram posts. On YouTube itself, in 2017, the term regional anesthesia produced about 18,500 results. And just looking at it the other day myself, it found about 98,000. So there's been a significant rise in the amount of regional anesthesia videos out there. And then on Instagram, visual posts with audio commentary help to promote newer, say, block techniques described in papers, but that have not yet made it to textbooks, so it helps with dissemination. Paper in 2017 looked at some of the specific advancements in social media around regional anesthesia. They found that regional journals have a higher performing journal impact factor, typically, if they have a higher performing Twitter account associated with it. There's this concept or this tag, #regional anesthesia, that collects topics including human anatomy, promotions for workshops, short quizzes, and annual meeting posts. There's a significant increase in conference conversation when associated with a social media presence. And that if people are using podcast formats, it allows for directed educational material, Ask the Expert forums, and case report discussions. So a lot of very interesting applications for the advancement of regional anesthesia education on social media. Another thing that came up was this #JanU Airway that was first developed in 2021 and has continued since. Came from this Dr. Tom Lawson's personal Twitter account and essentially created bite-sized series of one-pager educational material. Some topics including capnography, oxygenation, and tracheostomies. It's not unlike our own program's resident initiative, Airway, Breathing, Coffee. And this one had quite a significant amount of engagement. At the end of January 2022, they had about 31 daily tutorials with 4 weekly summaries, and that garnered almost 3 million views and quite a number of thousand clicks, likes, and retweets. Dr. Max Feinstein of YouTuber fame wrote a paper in 2021 looking at social media usage by anesthesia residents and residency programs. This was an American-based study, so they found 157 anesthesia residency programs in their database. About 70% had Instagram, 50-ish% had Twitter, about 40% had Facebook, and about a quarter had no social media presence at all. What was most interesting that they found, though, was that Twitter is the most popular social media platform for healthcare in general, but that Instagram is the most popular for anesthesia residency programs, potentially due to the ease of posting audiovisual components, and that the demographic of current anesthesia residency programs typically tends towards those using more platforms like Instagram. If we look at Canadian anesthesia training programs in 2022, this study tried to analyze the social media presence. They found 17 residency programs, of which there were 31 social media accounts. 16 of the 17 of those had at least one account, including Twitter, Instagram, YouTube, and LinkedIn. They noted about 4,000 posts on Twitter, about 400 posts on Instagram, very sparse activity on YouTube, though, with a median of about 25 followers per, and then only 50 posts that they could find specific at that time. Of note, 3 programs had accounts on 3 platforms, and 1 program had accounts on all 4 platforms. If they were to redo that, they would find 2 because our program is on all 4 of those accounts. The most interesting I found, though, was that there was no content on Instagram about anesthesia residency programs before 2020. So that, to me, notes a significant association with the rise of social media in the context of COVID and everything going virtual. Finally, there was this 2023 study looking at the influence of social media on the perception of American anesthesia residency programs by applicants during COVID. So again, when things were transitioning to more virtual interviews and meet and greets, and there was this lack of out-of-province electives. They found that almost 2/3 of applicants used some form of social media in deciding which programs to apply to, and that most were interested in resident life outside the hospital, again, primarily because they weren't able to go there in person. Over 2/3 also found that their perception of a program was positively influenced by the program's social media account. And they specifically say that having an up-to-date website and robust social media presence, particularly on Instagram, again, may become increasingly important in the virtual interview environment. So we're just about done. One final paper to look at here that sums it all up and looks at our role as anesthesiologists in social media in the future here. This paper is pretty recent, 2024, and it asked why we as a specialty should care about social media and how we can use it for the good of our patients. So they have a nice little summary slide that they included with their patient, or with their study rather. They talk about the benefits of social media and anesthesiology and that it promotes health information dissemination. It provides insights on the patient experience, public health, and important healthcare policy concerns, and that there's potential for education and professional development through social media. Of course, this isn't without risks. There's a possible spread of misinformation, as we've talked about significantly today. There's a potential for damage to people's reputations with legal implications. As a tangent, there was a study I found from South Africa that noted that 85% of anesthesia professionals there used some form of social media, either professionally and personally, though only about 5% had adequate knowledge of the ethical and legal implications of their social media presence according to their society standards. So a lot of people are using, even at a professional level, social media without really knowing the implications of where the boundaries are at a professional level. And then, of course, there's the potential for breaches of patient or physician privacy. So with all that in mind, I think priorities for the future social media use in anesthesia include improving and verifying the quality of medical information, educating healthcare professionals on the risks, benefits, and best social practices of social media, developing guidelines for individual groups and health systems regarding appropriate social media usage, and supporting the growth of anesthesia through technology. One other study I found noted that the current social media engagement among anesthesiologists, I believe it was in the United States, is quite low, even though they do have a lot of social media accounts. Namely, over 70% of anesthesiologists they surveyed had accounts, but only maybe 10% or less had posted at all within the last 0 months. So overall, they note in this 2024 study here that in order to optimize social media use in anesthesiology, healthcare professionals must understand the key drivers of social media use and to adapt to rapidly evolving technology. So it's been a lot. We've covered a lot of material. I think we've covered a lot of bases looking at the standard context of social media right now in its modern form. We looked at a few tools and a few frameworks, and then some examples of anesthesia, past, present, and future. But to summarize briefly, I think we can say that medicine is always going to have a complicated relationship with social media, and that appropriate integration is still very much a work in progress. Primarily, social media is an entertainment platform, so to make it something more educationally based is going to be a challenge regardless. I think there's been an exponential increase in social media usage, and it's provided us with an incredible data set of information that we could potentially research. I think there are multiple valuable tools that exist to guide you through the analysis of social media data, including frameworks that help you analyze studies using that data. You can use the tools if you're in a research environment, but honestly, just going back to those key core tenets, I think it's going to help you in your day-to-day when you're inevitably going to run into some healthcare information, or a patient is going to present you with some healthcare information they found on a social media platform and they want to know your opinion on it. And on more of a personal belief, I do feel that it's our duty to exhibit professionalism in every interaction and to provide our patients with high quality, easily digestible information. And in the modern landscape, that does include recognizing that social media plays a very large part. So including both that in-person and that online informational component. So we go back to our agenda. We've looked at all of these. We took an overview. We developed our toolbox. We looked at a few appraisal frameworks. We looked at examples of med ed in social media in anesthesia specifically. And we've taken a little bit of a glimpse into the future of social media potentially in anesthesiology. You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/USask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.